So again, housekeeping. So just to start, I'm Dr. Tansila Basran. I'm a family physician in the Toronto area, and I'm one of the board members for the Muslim Medical Association, as well as on the planning committee for the CMMHC. So right now, I want to remind you guys that, we love your comments. Keep them in the chat section if you're trying to give us feedback. If you have questions, please write them in the Q&A section, and we would love to keep track, and I will get our speakers to answer those questions in the end. Another thing is the more engaged you are, the more chances you get at winning prizes, including a ticket to our conference next year, as well as some Amazon gift cards. So keep them coming, and our hashtag is hashtag CMM8C. So post on our social media and tag @MuslimMeds on Instagram or Twitter. Other than that, please fill out the surveys and questionnaires that we have post conference, and let's always remember to check out our website at muslimmentalhealth.ca for resources and hopefully the slides later on. So to begin, I am so honored to be presenting our two speakers. So we had a little bit of a speaker change, but nonetheless, we have Dr. Farah Islam and Dr. Arfeen Malick, who you've met before. So to start with, I'd like to introduce this wonderful speaker who has done talks for us before. Dr. Farah Islam is an adjunct professor at Emmanuel College at Victoria University at the University of Toronto, teaching the course of Muslim mental health, research, policy, and practice. She explores mental health and service access in Canada's racialized and immigrant populations using both epidemiology and mixed methods research. Dr. Islam serves on the expert advisory panel for Nissa Homes and is an associate editor for the International Journal of Mental Health and Addiction. Dr. Islam orients her research and community work around breaking down the barriers of mental health stigma. And all I can say is she is just a superstar speaker. Our next person who you've met as well is Dr. Arfeen Malick, who is a psychiatrist completing a fellowship in the Child and Adolescent Psychiatry subspecialty at the University of Toronto. She's completed her medical school at the University of Calgary and her master's in clinical nutrition at Columbia University. Arfeen also serves on the board of the Muslim Medical Association of Canada, where she is the mental health director and one of our founding members of this conference that you are attending today. So without further ado, I will let them get started.
Assalamu alaikum wa rahmatullahi wa barakatuh. Peace be upon you all. Jazaki Allahu khairan. Dr. Basran, that was a beautiful introduction and so kind. I'm Dr. Farah Islam. I'm just going to kindly request for the conference, if I can kindly just share my screen and I can get started, inshallah. So I'll be presenting today on perinatal mental health in Muslim. Okay, jazakumullahu khairan. That's wonderful. Hopefully everybody can see the screen now. I appreciate that. All right, so to get started, Dr. Rida Hashmi won't be able to join us today, but inshallah, Dr. Arfeen Malick will be going through the case presentations for us because that's so wonderful for us to learn from. And so I really can't underscore the importance of peripartum mental health in our communities as someone who has experienced peripartum mental health issues myself. It's just something that it's so needed for us to speak about within our community. So I'm so grateful for the conference for highlighting this very important issue. I just want to say, of course, we have no conflicts of interest. Of course, this presentation is not meant to replace any advice of a healthcare professional. If you do feel you are experiencing any kind of mental health issues, please do seek out the care and the advice of a mental health professional or of a healthcare professional. Just to poll our audience today, we just wanted to ask who's in our audience today and what are you hoping to gain or glean from this session. Hopefully the poll questions are supposed to come up and you can kind of go through that, and always helps us as we go through the presentation. Here we go. Wonderful. So I can see that as well. So I'll continue. Please do vote and put in your answers as well while we go through it. So let's talk a little bit about prevalence rates of peripartum mental health issues, or about perinatal mental health issues. So we're looking at, of course, the perinatal period, just to offer a little bit of an explanation. That's really anything around the time of a woman giving birth. And so perinatal mental health issues affect about 15 to 20% of women in the general population, so consider about 1 in 5. And there can be mental health issues that can occur before delivery. For example, a woman may experience premenstrual dysphoric disorder. We'll talk a little bit more about that. And after delivery, there could be other postpartum mental health issues, for example, like postpartum blues, postpartum depression, anxiety, and postpartum psychosis. And there are a whole host of sort of social factors or environmental factors that we're also going to be talking about that could potentially impact a woman's chances or risk of having or developing peripartum mental health issues. So for example, 40% of moms, so 4 out of 10 moms who have a newborn who is in the NICU, so needing that sort of extreme and intensive kind of care, you can imagine the incredible stress that a family would go through at that time. 40% of moms in that having that experience would experience peripartum mental health issues. So we'll talk more about those risk factors. So talking about—
1 second. Sorry. You are so energetic and we love it. The only thing is our closed captioning typists just need you to slow down just a little bit so that we can get all the words that you're saying in.
Sure, Dr. Busman, I appreciate that. Thank you. I will try my best. Forgive me, I do speak fast. Okay, so premenstrual dysphoric disorder. If we're considering mental health issues that a woman may experience potentially prior to having given birth, this is a mental health issue that occurs within 3 to 8% of women, and usually it impacts women in their 20s or early 20s, and oftentimes it's as a result or a family history of PMDD in the family can be involved. And just to link it back to postpartum mental health issues, having a personal history of moderate to severe premenstrual dysphoric disorder actually increases your risk of postpartum depression by 2 times, by 2-fold. But the research in this area is actually kind of limited or isn't quite conclusive. Some researchers say that there is a very a link between PMDD and your risk of peripartum mental health issues, and others haven't quite been able to make that link. But it is important to know and to understand. And if you do have a client or a patient who does have premenstrual dysphoric disorder, just to keep that in mind if she is pregnant now herself. Okay. So talking more about prevalence rates, the prevalence rates of postpartum depression in Canada are at about 8%. And for postpartum psychosis on the most severe or the most rare end of the spectrum when it comes to postpartum mental health issues, is about 1 to 2 cases per 1,000 births. And since we are trying to focus as much as we can on Muslim women for this talk here today, we're going to have to use proxy measures, because in Canada, unfortunately, a lot of our research, especially when we're looking at big data, doesn't take into consideration or doesn't ask about religion. And so it's hard for us oftentimes to really understand then what is the context for Muslim populations in Canada. So we're going to do our best using different proxy measures. For example, immigrant women are 2 to 3 times at a higher risk for postpartum depression in comparison to those women who are Canadian born. And so it's just something to consider. Again, if you do have a client, if you do have a patient who is an immigrant, and if you know, to ask about the migration history, what that was like, what the trauma, the migration trauma involved, and just to understand some of that context, because it can increase one's risk of postpartum depression. To continue with that, this study looked at the mental health of women 4 months after giving birth, and looking at sort of a whole host of different postpartum mental health issues. And it's seen here that if you're looking at migration class or the circumstances of migration, it's really important to understand. And you'll notice here that asylum seekers and those who are refugee mothers have the highest rates of peripartum mental health issues. So they have the highest risks of postpartum depression. They are most likely to have thought about self-harm. They have the highest rates of physical abuse in the past year, the highest symptomology of post-traumatic stress disorder, and also symptoms of depression, somatization, and anxiety. So again, something really to consider when we're talking about migration as being this sort of social determinant of mental health and what it means for Muslim women and women just generally. And so now I'm going to give it away to Dr. Arfeen Malick, who's going to very kindly offer some illuminating case presentations.
Jazakallah khair, Farah. It's so nice to have you. And I just wanted to acknowledge that Dr. Rida Hashmi really intended to be here. She has a family emergency. She sends her apologies for not being able to be with you today. So just to start off with a case, we really would like this to be interactive a little bit. And so in the chat, we're just going to go through a few cases and are hoping that you'd be able to offer what you think might be happening in this scenario. So the first case that we have is a 30-year-old female, first pregnancy. She has some mild anxiety during her pregnancy. She did have a C-section, so a cesarean section, because she wasn't able to progress to labor after a 36-hour labor. She was not able to progress to delivery. So she didn't have other complications though. 7 days after delivery, she feels very tearful. She's crying very easily and she's worried that she's not doing things right. So constantly asking people if she's doing things right or questioning herself. She continues to enjoy her baby, and 14 days later, she starts to feel a bit better. She's no longer tearful or anxious. So in the chat function, we just were wondering if you could share some of your thoughts about what you think might be happening for this young lady. So we have some saying postpartum depression, some saying feel confusion, like there's some confusion, some saying that it's a natural hormonal imbalance that corrected itself, postpartum reactivity or baby blues, acute stress, depression. Okay, so this is wonderful, and I'm so glad that you guys are messaging in here and are participating. This is great. And you're right. So the ones that have messaged saying that this is postpartum blues, this is postpartum blues. And as you'll see on the next slide, there's a few things that really hint us towards that. And a few people had wondered, is this depression or is this postpartum blues? So is this kind of a normal part of delivery, or is this something that actually needs some higher level of medical attention? And those are great questions. That's exactly what we should be thinking about. So for baby blues, it's actually very common. And so the literature actually says that it spans from 50 to 85% of women. But as you can imagine, for most of these things, there's underreporting. So, I mean, and spreading from a half to 85%, really, like we're talking a lot of people, most people are going through baby blues. And so what we do know is that there is a percentage, though, of people who have baby blues who do go on to develop postpartum depression. But what's great in this case, if we flip back to it, is that we can see that she starts to improve in her symptoms 14 days later. And that's really what we would expect if this was postpartum, if this was baby blues and not postpartum depression. With postpartum depression, what we'd be looking at will present something later on, but really persisting longer is what we'd be looking more for, and some more functional impact. So indicating that there's a severity and a greater severity of symptoms that's happening. And so another key part of that case was that she was enjoying her baby, and she was able to really enjoy that time despite having these overwhelming amounts of emotions that were happening for her. And someone commented in the chat that the hormones, and you're so right. I think when you go through pregnancy, you really have a renewed sense of how hormones impact you. And so that's very wise to say. And definitely we know that's a normal part of postpartum time where hormones are really fluctuating rapidly. So we'll go on to the next case. And this case is of a 26-year-old female. So she did have one previous loss. She's a new mother to a 6-year-old baby. Not a complicated pregnancy, alhamdulillah. She delivered well. Her partner did take 2 weeks leave, and her mom lives close by. She's sleeping very poorly though. She's losing weight because she doesn't feel like eating at all. And she's finding it really hard to enjoy any time with her baby. Even though her baby just started to do a few smiles, she still is quite irritable and is quite tearful. And the baby is at 6 weeks old now. So what are some of the thoughts about what could be happening here? We have postpartum depression. Yeah, lots of postpartum depressions. Okay. And so I know we have lots of definitelys. Definitelys. Okay, great. So that is really great to hear. So as we'll see on the next slide, it's really important to identify though. And so a lot of people, they brush things away because postpartum blues is so common, and it is very, very, normal as a part of delivery for a woman to feel emotional changes. But postpartum depression is different. And now postpartum depression, as you can see, there are these, all of these symptoms listed here: feelings of hopelessness, a loss of interest in your baby, feeling tearful all the time. The part though about lack of enjoyment is really key. So that's a really important part. If you're not able to enjoy your baby's presence, you're not able to enjoy things that are happening in your life, you're not looking forwards to opening any of the presents, it's fine if you don't look forward to cleaning up poops and diapers. That's very normal. But when you see that it's impacting your enjoyment of things that you normally would really enjoy, that's really key. Loss of appetite, as you saw in this case. And then when we talk about thoughts of harming ourselves, that's when we know that it's really reached a point where it signals that there's something really intense going on and that we definitely need help. And that's why postpartum depression is really serious in terms of us being able to distinguish it from postpartum blues. And so I'm so glad that a lot of you were able to pick up on the differences. And for those of you who are kind of thinking about what's the real difference between those two things, I think the safety risk is a really important one, and it's an important one to screen for in all new moms who come to you. If they're talking to you about a change in emotion, it's really important to just make sure that they're doing okay and to check in with them. And there's nothing wrong with checking in. So making sure you're asking the question about, are you having like thoughts about, just not wanting to be here anymore? I know, in Muslims, they don't usually use the language of I'm feeling like I want to end my life. And that's not really something that we have in our language. But a lot of times we would say things like, I just want this to be over. And, I want to return to Allah subhanahu wa ta'ala. And though they're talking like that. And so those are really things to kind of key in on. And then the other symptoms here being more of impacting your function. Now at the bottom, we do have a few comments about medications, right? So there are times where medications can be quite effective, but there are also psychotherapies that can be useful as well. And so there's both. And there are medications that have been shown to be safer in breastfeeding, such as sertraline and kind of the newer studies. So we can move on to the next case. So the last one that we wanted to talk about is a 35-year-old mom who 48 hours after delivery is getting ready to leave the hospital with her second child. She won't let the nurse come in to see her kid because she thinks the nurse is going to poison her baby. So she starts acting more and more angry and is shouting and irritable and yelling. Her husband can't seem to calm her down, doesn't know what's happening. She doesn't normally behave this way. She states he is involved in a secret plan with the doctors and nurses. So I already see a few comments coming in. Some people saying it's paranoia. Some people saying it's postpartum psychosis, or they're acutely psychotic. And so I'm glad that so many are able to think about this. I'm actually very pleasantly surprised that people are able to think about this. And the reason is that as we go to the next slide, you'll see that postpartum psychosis is actually quite rare. It's not actually that common. It can happen anytime after delivery, but usually it's within the 2 weeks, up to 2 months, though, that it can happen. Risk factors are having your first delivery, history of postpartum psychosis, having a family history of postpartum psychosis, and also if you already have depression or bipolar disorder, you're at increased risk. The hallmark thing with postpartum psychosis is that patients and individuals normally feel quite confused and quite perplexed, and they will not be able to come to you to let you know that they're feeling this way, because they, unfortunately, during that time, it's very confusing for them and they don't have a lot of insight into what's happening for them. And so you do need to be a bit more directed with your questions, asking them specific things like, does it seem like the baby is doing something to harm you, or that you might want to be doing things to harm the baby? Oftentimes we hear the baby's rejecting me, or the baby likes someone else better. And that's a really unusual thing for other moms to say, but in postpartum psychosis, that comes up a lot. Usually, as I mentioned, other people notice it before the mother, so usually the partner or other support figures. And there is a very high risk of recurrence, so about 70%. And the reason this is a psychiatric emergency, is what we call it, is because there's 4% risk of infanticide and 5% risk of suicide. So it's really important to get emergency help as soon as possible. So now I'll hand it back over to Dr. Islam to take the rest of the presentation away.
Jazakallahu khairan, Dr. Malick, that was fantastic. And I hope those case histories or case studies were really illuminating for you. It's really important to hear those stories for us to appreciate what women go through, and just how difficult it can be. So we'll move on to the third part of our talk, where we wanted to cover some of the impact of perinatal mental illness. And really, of course, this is an impact across the whole family, for everyone. It's not just the woman, not just the child, the partner, everybody involved is impacted by perinatal mental illness. And so if we're looking at the impact on mothers, as you can imagine, if a woman is experiencing postpartum or peripartum mental health issues, it's likely that she would have decreased compliance to her obstetrical care, right? This mental illness could also increase her risk of other sorts of complications during her pregnancy. For example, spontaneous abortion, preeclampsia, having to go for a C-section. She may start to interpret or perceive the behavior of her baby as being more difficult to manage than is actually maybe the case. And related to that, she might have a difficult time interpreting or responding to the baby's cues. So basically, the different types of crying. What does the baby want? Tired, sleepy, hungry, what's going on? And just the needs of the baby. And you can especially imagine that within, for example, the case of postpartum psychosis, as Dr. Malick mentioned. And then also, as you can imagine, if it's so difficult, so stressful, the mother is going through this really difficult time, it may lead to a shorter duration of breastfeeding. Of course, that having long-term impact for the child. And as well, substance abuse may be involved. And as we were mentioning, particularly, for example, for postpartum psychosis, there's a risk of suicide of the mother, or of neonaticide or infanticide, or of killing her baby. So really is so important for us to highlight these issues, and for us to really examine how we can help women get the help that they need, right? It can become a very dire situation. There is, of course, as well, impact on the newborn, on the child themselves, right? A child, if their mom is unable to interpret their cues or their cries, will likely cry more frequently, have a longer duration of those cries, and be more agitated, as you can imagine. The child may be at a greater risk for developmental delay, might be a greater risk of forming an insecure attachment, which can, of course, has long-term ramifications for their own development of their healthy relationships later on in life. Insecure attachment can also be associated with risk of psychopathology as a child or an adolescent. So for example, some of the work that I do with South Asian youth here in Toronto, it was really interesting when I interviewed them. It was really interesting to find that many of the South Asian youth that I spoke to were currently themselves seeking mental health services. And one thing that they mentioned was that it's likely that their mothers experienced some type of postpartum mental health issue, maybe likely postpartum depression, and were unable to get help. Were unable to seek help, whether it was because of mental health stigma, whether it was because of the fact that, often within our families, within our communities, we feel that, to hold it in, to be stoic, to be strong for our family, that's what our family needs, right? This idea of having to get help is a sign of weakness, or that will actually, impact our family even worse. So we try to keep it in and try to be strong, quote unquote, for our families. And so a lot of mothers were kind of put into this very difficult situation where they were unable to get help. And it was an interesting trend to see then that their children then later in life as young adults, as adolescents, then went to go on and seek mental health services themselves because of mental health issues that they were facing. So you can understand the sort of the long-term ramifications for the family in terms of parenting, in terms of insecure attachment, and other difficulties that can arise if we aren't able to get the help that we need at that time. As well, mental illness is associated with increased risk of complications for the child themselves during that time. So prematurity, having to stay in the NICU, etc. Also, and what was interesting for a lot of people, I think, to discover is that, fathers can also get postpartum depression, right? There is such a condition as paternal postpartum depression, right? It's actually 1 in 10 fathers. And that's actually, I think, surprising or shocking for a lot of people to hear. And this peaks around the 3 to 6 months postpartum or after giving birth. And the strongest predictor of a father or a partner having postpartum depression is having a partner who has postpartum depression. So the mother themselves, she is going through postpartum depression after giving birth to their child. And about 50% fathers who develop postpartum depression, 50% of the time it happens to be that their spouse or their partner is also experiencing postpartum depression. And so it's, again, something really important to highlight. And we need ways to really be able to appreciate what fathers are experiencing when the stress becomes so incredible and difficult to manage within the home, as you can imagine. What are some of those then risk factors of developing postpartum depression? And really, this is a multifactorial model. There are biological factors involved, psychological factors, social and environmental factors involved if we're looking at the social determinants of mental health. So if we're looking at the biological factors, for example, having a past history or a family history of depression or anxiety, bipolar disorder, any type of mental health issue, past history of having premenstrual syndrome or premenstrual dysphoric disorder, which we highlighted, can also increase your risk of postpartum depression. Having a newborn within the NICU or being a colicky baby, crying a lot, having a difficult temperament, just imagine the sleep deprivation and what that does for any of our mental health. So you can imagine sort of the extreme sort of situation that can often lead to. And then all the hormones, there are many of you that mentioned in the chat during our question and answer, hormones, right? Just this huge fluctuation in hormones. A woman's body goes through so much during birth. I remember reading that it's like after giving birth, your brain has gone through so much change. It's like you give birth to a whole new brain. So subhanAllah, and actually I mean that for real. It's like as if we've given birth to, we have an entirely different brain after giving birth. So you can just imagine and appreciate how much change is going on, and how stressful that can be for a person to go through so much all at once. There are also, of course, psychological factors that lead to one potentially elevating their risk of postpartum depression. So for example, having a difficult relationship, particularly with their mother growing up, having an ambivalent or a negative attitude towards what it means to be pregnant or to become a mother, right? We live in a world now where there is so much pressure on us as women, right? It is literally expected you have to be a superwoman, right? You have to be a star in your career. You have to be the most amazing, most involved mother, you know, volunteering on the PTA. I mean, doing everything, homeschooling somehow as well. I mean, you're doing everything. You're juggling so much. And so you can imagine that a lot of women, when it comes to this whole task of what it means to be a mom, what it means to be pregnant, and suddenly your world shifts and changes, it can be difficult. It's a difficult shift, a difficult change. And also oftentimes we kind of idealize what it means to be a mom. And when a lot of women are thrown suddenly into this situation of becoming a mother, there's this huge difference between what they were told, what was the ideal, what they expected, and what it actually is. You know, those sleepless nights, the incredible sleep deprivation, listening to a baby crying for what seems like 12 hours and you can't hear anything other than the baby crying. It's really difficult. So subhanAllah is something that that just factors that we really do need to appreciate. And there are social determinants of mental health as well. For example, not having the social support that you really need, especially from your partner, not having that open line of communication, living in a low income situation, a low socioeconomic status situation, being of racialized status, being an immigrant, for example, as we talked about how refugee women, asylum-seeking women have the highest levels of peripartum mental health issues, and how difficult that is, and that idea of migration as being traumatic, right? And what that causes, what that leads to for a person. And also living within an extended family. And that's actually what we're gonna talk about in the next slide. So there's this really interesting research study done in Britain on Muslim mothers who live in extended families or intergenerational families. So consider, usually it was the situation of women living with their in-laws, and what that meant for them as new mothers, and the kind of difficult conflicts that then arose often. And so it was a very interesting finding where they found basically that Muslim mothers who live in this intergenerational type of situation had significantly higher levels of mental health problems. Actually, they had levels of depression more than 3 times as high as those diagnosed as having cancer. And so I'm going to say that again, because I think it's almost shocking to hear, and so important to highlight, that women who live within an intergenerational home, usually living with their in-laws, have levels of depression more than 3 times as high as those diagnosed with having cancer, right? So subhanAllah, just glory be to God. I mean, you really have to appreciate what can be an incredibly stressful situation and how that can impact a new mother and a new family at this time period. And I also just want to highlight, you know, it's never an either or situation, right? As mental health providers, as those working with those who are dealing with mental health issues, you know, there is an incredible it's a source of blessing, source of barakah, right? Taking care of our elders, being able to be in a situation where we can provide care for our in-laws or for our own parents. And they can offer a great amount of support as well, absolutely. But on the flip side, it can also become a source of conflict for many families. And I think when we are working with our clients, where we are working with our patients, when we do ask them what their living situation is, and if they are living with their in-laws or living with their parents and being caregivers or care providers for them, just to ask more and to try to understand then, what are the positive parts of that experience, as well as some of the negative, and helping the woman really get through some of what can be a difficult situation. As again, speaking from personal experience, I did live with my in-laws for the first 7 years of my marriage, and I spoke to a lot of women who are in a similar situation. And generally speaking, if we're talking about mental health and sort of the mental health impact of what that situation does, I remember one woman saying that she didn't recognize herself anymore. And for me, it made me stop and think about that and really reflect, because the thing is, in that situation, which can often be so much conflict, it's conflict, it can be an external conflict between you and your in-laws or with your parents, or external conflict with your spouse. But more often than not, I think the majority of the conflict is within yourself, right? And it's this huge fight against yourself, because you're trying to do what is quote unquote the right thing. You're trying to do something for the sake of God, trying to take care of your elders. And you're trying your best with the best of intentions, and yet it's still so difficult, right? And so it's and oftentimes a lot of women that I spoke to just get to a point of bitterness, anger, resentment, and just constant conflict, where they feel that they don't recognize themselves in the mirror anymore, right? They just don't know who this person is anymore when they look at themselves. So if we're working with our clients, it really is about trying to help them through that loss of identity, and trying to get them back into a place of empowerment, where they remember sort of who they were once and their reasons for, why they made that choice, and how to get through some of those conflicts, inshallah. So what are some ways that we can prevent peripartum mental health issues from happening? Of course, being able to communicate our needs to our spouse, to our family. If we're living within an extended family, being able to have that open line of communication helps so much. Being able to surround ourselves with the support system that we need, if that includes family members, if that includes our spiritual support group as well, having all of that around us. Having a schedule, again, really hard when you haven't slept, but trying to schedule your days, feeding times, everything with the baby as much as you can. Spend time with mothers who can actually relate to you. And this is big, right? Particularly if you are experiencing peripartum mental health issues, it may be that your experiences are not going to be like what other mothers may be experiencing, particularly, for example, if you are more on the more severe end of peripartum mental health issues. And so it's not helpful in those situations, honestly, to talk to moms who are having a really easy time. Their baby sleeps through the night, feeds like a breeze, right? It's not helpful to hear that. So really trying your best to, whether it's to go into early years centers, find postpartum health, postpartum mommy help groups, just finding places where you can actually be heard, and to find your actual experiences, be empathized with, is so important, so you don't feel further isolated. Drop-in classes, of course, at the community centers, at libraries, so important. Play dates, being able to have that constant engagement and that social interaction, because again, when you become a mom, it can be a very isolating experience for a lot of us. To exercise as regularly as possible. Again, it can be a tall order, but so important, inshallah, if you can manage it into your day and accept help whenever you can. Again, very difficult for a lot of moms to be able to accept help. Get rest whenever you can, but inshallah. These are what we can work towards. I do want to highlight that in our Muslim community, it is so amazing to see that our mosques are actually now having early years programs or mommy and me programs. What a fantastic way to promote maternal and child's mental health. I think this is so beautiful. Again, I know pre-COVID, but ISNA Canada, which is one of the largest mosques that we have here in Toronto, had this amazing Me and my little one program right in the mosque, right? Having moms and babies come in so they can meet each other, have that social time, just so important again, and just such a beautiful and powerful way to highlight how important maternal and child mental health, peripartum mental health is for Muslim communities. And when it comes from within our mosques, when it comes from, our religious authorities, and they're saying it's so important that we're going to have programs in our mosque, that's so beautiful and that's so powerful. And may Allah reward them for their initiative. And I really hope we can see more of that across our city and across our country. So, and then we also wanted to highlight in this talk some of the barriers to care, because I think we do really need to appreciate why it's so difficult for Muslim women and for women in general to be able to get care at this very critical and important time in their lives. So again, because it's so difficult for us to get research on Muslim women, it's specifically, we are going to look at the barriers for immigrant women, just as a more general sort of construct to look at. And of course, not all Muslim populations, not all Muslim women are immigrant women, but we're just going to be using this as best as we can. So many of the speakers actually talked about how, as a result of mental health stigma and a whole host of different factors, it is very difficult to ever talk about any kind of mental health issue you may be experiencing. Now, for women and for Muslim women, generally speaking, it's very uncomfortable to talk about emotional problems, family problems outside of your family, right? Within our faith, we have this concept of, it's wrong to backbite. It's wrong to say anything about anybody that is unkind or hurtful. And so I think many women often then bottle things inside, hold everything inside because they're afraid that the words that they are saying could be sinful. And I understand where that's coming from. But of course, as mental health providers, as counselors, right, we are offering help. And so and when we do have a client who feels reluctant to disclose and to talk about what she may be experiencing, we can then remind them that when you are sincerely trying to seek care and seeking advice, then it's all right to talk about what the problem is, and to that's not considered backbiting in that instance, because you're sincerely seeking advice, if that makes sense. Also, women are often emotionally and economically dependent upon their spouse or upon their families, so it makes it hard to get mental health care, which can be so expensive, as we know. There is that as well. Women are scared that it will burden their family, basically, if people find out that they've gone to seek care, and a real fear as well of losing their children to the authorities, right? For example, in cases of postpartum psychosis, for example, Children's Services might open a case against you, depending on what the circumstances were before you were able to finally get to the hospital and get care. And so, these fears are real, right? These are incredible barriers that exist for Muslim women, and it makes it very, very, very difficult to get care. And so what we can do to mitigate some of these barriers, that's what we're all here for, to brainstorm, to come up with those solutions, inshallah, together. And so the last part of our talk is going to be talking about some of the evidence-based recommendations, what we can do as mental health care providers, as just people in the community who care about our community members. What can we do to help those suffering and in a difficult place? So here's one study that I wanted to highlight. This one was with Somali new mothers. Now, of course, Somali populations, the majority are Muslim. So we're using this again as the proxy for Muslim populations generally. And this is a great study in Norway and the US looking at Somali new mothers and their childbirth experiences. And their recommendations from this study was that we really need to incorporate cultural and religious practice into our sort of nurse care, as well as family support and perinatal care. That's sort of the best way forward and the best way that we can support Muslim families. So increasing promotion of postpartum public health nurses. Again, because public health nurses are able to go into the home, they're really able to see the family dynamics, what life is really like inside, and have a long-term relationship as well with the client. And so it, especially in cases where there is less severe depression, public health nurses or those who are offering that in-home visitation are better able to identify women who are at risk for peripartum mental health issues. So if we can augment that service within our country, within our province, it helps a long way in helping women get the help that they need. We really need better ways to assess postpartum partner support as well. Is the partner, is the extended family, if the woman is living within an extended family, are they sources of support for the woman? What are the pros and the cons? What's actually going on? Again, very important to be able to assess. There's also been a great study that saw that peer support telephone intervention for new moms actually significantly reduced peripartum mental health issues for new moms. So, in Canada, we have two great Muslim mental health helplines, right? So we have the Nasiha Muslim Youth Mental Health Helpline, and we also have the Nisa Muslim Women's Helpline. And so I think there exists such a great potential and a great opportunity for these helplines if you can train callers, or train the peer support worker to be to offer that kind of postpartum support for new mothers, and then to match them with new Muslim mothers, and to offer that sort of social support by calling up and actually in COVID, this is a sort of absolutely possible and viable as a solution, but offering that sort of social support can really help. It just helps to be able to talk to somebody. And yeah, we, alhamdulillah, in our community, we just have such great potential as we have two mental health helplines already existing. And and just an overarching, if we're talking about recommendations, one of the sort of issues, one of the difficulties that we have with our mental health system in Canada, that it really is sort of a crisis management system, right? It doesn't take a public health approach, or it doesn't often take a mental health promotion approach, right? We're often not trying to prevent mental health issues or mental health crises from happening. We're just jumping in when the crisis happens. And that's, of course, not the best way to build our communities and to build our society. And so, any types of programs that we can create that promote social integration, that reduce poverty, reduce social inequity, etc., goes so far in helping new families in this very difficult time. I also wanted to highlight some I guess, research on perinatal loss, on pregnancy loss, and grief. And bereavement, because I think we don't talk about it enough, and I think it's absolutely involved when we talk about peripartum mental health issues. So in this study that was looking at Pakistani women in the United Kingdom, and again, most Pakistanis are Muslim, so again, we're using it as a proxy measure for Muslim populations generally. So this is one case or one story from a woman whose son was stillborn. And she basically said that the only person she could talk to or cry in front of was her husband. And she was really, really reluctant to speak to the hospital counselor. And just because it just, again, it seemed very foreign to her, and often is very foreign to us in our families or in our communities, to talk to strangers about very personal, emotional difficulties. And so if we take the recommendations from that study, trying to improve the communication as well as privacy within the hospital during that period of grief for new families is really important. Trying to improve the access of family members or friends, others who can provide that social support for the mother, for the father who is grieving after the loss of their baby. Again, very important. And this another a study in Malaysia amongst Muslim families highlighted how after a pregnancy loss or after a stillbirth or after a loss of a child, what helped Muslim women was that to have reminders from their husband or their family or their friends about this idea that perinatal loss as being a test from God, as being a test from Allah, and that actually helped improve their sense of self-worth. And Dr. Rania Awad, she started off, kickstarted today's conference, and she really talked a lot about this sort of beautiful concept, and other speakers actually as well today talked about how this idea of thinking about the trials, the hardships that we face in life as being something given to us by God, that there is a greater wisdom, there's a greater reason for why we go through what we go through, right? And that God never burdens a soul more than what we can bear. That if God gave you this difficulty, this hardship, this loss to face in life, he gave it to you because he believed that you were strong enough to go through it, that you were strong enough to survive it, to learn from it, and to grow again, right? And that's such a powerful reminder for us as Muslims. And if we can provide opportunities within the hospital space, within whatever mental health care space, to really offer that positive reinforcement and for the mother, for the father who has just experienced this loss, it can be so powerful and just a powerful reminder of our faith. I'm always reminded of this beautiful hadith or a saying of the Prophet, peace and blessings be upon him, where he says that that the fetus that has died, the baby that has died, will basically pull his or her parents into Jannah by the umbilical cord, right? That is such a powerful imagery when I think about that, when I try to picture that, but it just is such a powerful reminder of the mercy of God, right? Just to remind the family that is grieving, that is heartbroken, is broken, right? And is shattered after this loss, just to remind them that God sees your tears, that Allah subhanahu wa ta'ala knows what you are going through, knows your pain, and you are not alone, right? He would never leave you in your sorrow. And it reminds me too, there's this great book, if you're talking about positive psychology, there's this great book, Flow, which is a national bestseller, super popular book by Mihai Csikszentmihalyi. And, he basically went all over the world. He's trying to find basically the secret of happiness. He is sort of the preeminent scholar of positive psychology, and he wanted to basically understand what makes people happy, what gives people a sense of fulfillment or meaning in their life. And so one really interesting and cool finding that he highlights in his book is that Muslims were actually some of the happiest people that he interviewed. And he explained that the reason for why Muslim people were so happy or felt so fulfilled or had such a sense of peace in their life was that because Muslims found meaning in their suffering. They had this concept, they had this idea that God always has our back. There is a capital R reason for everything that we go through. Our hardship, our suffering, our tears are never in vain. And that is such a powerful, hopeful message for us as Muslims, and gives us such meaning through our hardship, our suffering, our difficulty, that it makes us some of the happiest or most fulfilled people that Mihai Csikszentmihalyi actually came across in his research, right? So subhanAllah, so powerful, and something for us to reflect upon as mental health care providers. How can we provide that hope and that sense of meaning and purpose back to our patients and to our clients? One great study I also wanted to highlight that I got to be a part of, and many of, as you can see, many of the authors are the fantastic presenters and the organizers of this conference. One finding from this project where we went into mosques and had a spiritually adapted psychoeducation program that was basically trying to mitigate or decrease the stigma that our communities often have towards addiction. And so it actually significantly reduced mental health stigma within Muslim populations. And so when we're talking, for example, about peripartum mental health and about the mental health stigma that can surround peripartum mental health issues, then here there is, again, great opportunity for us to have these conversations in the mosque, right? To go into our spiritual or to our community places of congregation and to talk about peripartum mental illness. Have women, have families come and share their stories of what it was like to go through baby blues, postpartum depression, postpartum anxiety. What was that experience like? And to share. And for our spiritual leaders, our imams, to talk about it and to, again, really destigmatize what it means. But having these kinds of workshops within our spiritual settings can significantly reduce stigma, and so important, again. So recommendations: to have spiritually adapted bereavement support for our Muslim populations, and also create spiritually adapted anti-stigma programs, right? We can create the best mental health service programs ever in the world. But if we cannot reduce mental health stigma within our communities, if we cannot reduce the barriers that exist that make it next to impossible for families to get the care that they need, then there's no point, right? We need to be able to, right, in parallel, always be trying to develop the best programs we absolutely can, and at the same time, doing our best to decrease mental health stigma in our communities as well. And again, more overarching types of recommendations here: early childhood education and offering parenting support programs, for example, like the Triple P Positive program, which the Public Health Agency of Canada actually recommends as being best practiced and evidence-based, is so helpful. It just goes in such a long way to empower families, empower parents. Becoming a parent can be, again, this very isolating, difficult experience for many of us. A huge shift. It causes a huge shift in who you once were, in your identity, in the dynamics of the home. And a lot of us can often feel lost and often feel unsupported. Think, for example, about a new immigrant family suddenly having to become new parents in a new country, right? It's very difficult. You've lost your entire home, lost your entire support system, and everything that you knew. So really having these types of early childhood education, parenting support, early years centers, public health nurses, etc., just being there to offer that real support for parents and for families just really helps to reduce peripartum mental health issues. Jazakum Allahu khairan. Thank you so much for being a part of our presentation here. Please do keep in touch. We would love to continue the conversation, and we will now have a Q&A session. So Dr. Arfeen, Malick will join us again, inshallah. And yes, we'd love to hear from you. Please do share your questions.
All right, thank you so much. That was not only informative, I think it was just very eye-opening as well. those numbers and the stats are things that we don't often talk about. So I really, really appreciate you coming and speaking to us, and hopefully doing more research on Muslim women and Muslim men and our mental health. So I have some comments and questions. So something that someone asked is, do you have any recommendations for mothers who feel disconnected from prayer during the perinatal period?
Do you want to take that?
Sure. I mean, I'm happy to take it. I think, and then I'm sure Farah, you have lots more insights as well to add. So, my insight with that would just be really asking first about that disconnection from prayer, because if previously you've been someone who really finds prayer to be a good coping mechanism for you, and you actually get a lot of enjoyment out of your spiritual practices, then that's a really big shift for you. And I would wonder about if there's a little bit more going on. You know, we talked about that, the difference, right, between postpartum blues and postpartum depression. And when people say that they start to lose the things that they really used to enjoy, that's kind of a little bit of a flag for us to think that there's something else happening, and maybe the impact of something else that's happening is a little bit more than we realize. So that's the first thing that I wanted to just highlight there. And then the second, sounds like you're looking for some strategies to help to become more connected in prayer. And I think if there is something like a depression or another mental health challenge that's happening at a time, or a stressor, really recognizing that and then addressing that is probably going to be the first thing. So that's probably going to be the first step to help you to be more connected in prayer. And then there's all the steps that our wonderful scholars kind of talk about how to be more present in prayer, like increased God consciousness, like doing things in prayers that help us to connect, like when we're doing sujood, making like sincere, you know, du'as that are specific to ourselves, memorizing new du'as that we can say so that it's, you know, a different, it's different each time. But I do think that there's a little bit more to that question. And I think maybe addressing what's causing the disconnect is the most important part from my perspective. Farah, did you have more that you were thinking about?
No, that was great, Arfeen. I guess I would just add, just to be easy on ourselves, I think it's such a difficult time, whether it's the sleep deprivation, you're starving, whatever it is. And I think you can start to beat yourself up and kind of get mad at yourself if you feel like you're not connecting enough in prayer, or not connecting the way you wanted to. If there is an opportunity where you can accept help, ask someone to take the baby for a bit, be able to rest, to eat as much as you need to, and then see how prayer goes for you there, where you feel those parts that are missing maybe are taken care of. And if that makes a difference, then alhamdulillah. As well, maybe some of that reflecting before you go to bed, maybe highlighting some of the wonderful things your baby did that day. Every day is some kind of a practice. It helps develop, again, I know it's a very difficult time, which is why it feels so exhausting. But I think there are sort of strategies that can be done. And if there's something deeper, there are peripartum mental health issues there to, inshallah, try to get help. Absolutely.
We had someone in the comments to just offer a few other suggestions. I guess she works with perinatal women. And if you are unable to pray and you're unable to do salah because of nifas, then you can do dua or dhikr or tafakkur. And so those were suggestions that I thought were really great as well. And also for amazing suggestions, because we are so hard on ourselves after the postpartum period. So very good suggestions.
Great suggestions by our wonderful panel. So another question, and forgive me if I'm interpreting this wrong. So I think someone asked, how can we make people aware of their trauma within a marriage or with childbirth that may be causing postpartum depression? And what's a safe way of, I guess, maybe approaching people so that we have their well-being and safety in mind?
I did find that after I gave birth, some of my friends would ask me, you know, I guess a very open-ended question. They would tell me, Farah, what was your birth story? Or what was it like? And I think maybe offering that safe space opens up that conversation in a very neutral kind of way, where they can talk about if there was trauma involved, if it was a difficult pregnancy, if it was a difficult childbirth, what that was like for them. and maybe it leads to a greater conversation then down the road.
Yeah, I think I'm not sure if this question is also speaking to what Hiba and Rahaf had talked about earlier in terms of safety when we're talking about trauma, and so I think that approach that Hiba and Rahaf really went through, and making sure that there is a safe space, that you have the time, and then you also have the support to have that conversation. These conversations about trauma are not 5-minute conversations; they're going to be longer, and making sure that the person has a safe person to talk to after you, or the supports that they need in place, because the conversation can be really challenging.
All right, so someone had more of a comment, but I don't know if you have anything to add to that, is about the stigma that parents may face when they have abortions or voluntary abortions for various reasons, and the distress that can happen from the shame, or just the difficulty of having these talks with family and friends. What's any comments on how to cope with that?
Arfeen, I'm gonna give that to you, inshallah.
Sorry, I'm just going to read it over because I was reading a comment. Could you just read that question again?
So the exact comment was, another stigma not to forget is one of parents who deal with voluntary abortion and who can have severe distress that they can't share with their families or in communities due to shame. So it's more of a comment, but I'm just wondering if you guys have any resources or tips for coping with that.
Yeah, definitely. So that's a really good point that someone brought up. And so not only are there losses, but there are also, losses in all respects. So whether it's a voluntary abortion or an involuntary abortion, or something happens during pregnancy, those are all losses, and all losses are not treated equally, because it depends on how it's impacting you and what you need as a support during that time. And so for some people, when they experience a loss, they don't want others to be involved. And for others, there is a sense of guilt or shame, or a sense of isolation, because, as you mentioned, Tanzila, and in the comment as well, like it's stigmatized, and so it's really hard to openly tell your story to people because you worry about what the reaction may be like. And I think talks like this are really important in trying to take that pressure off of a person. You should really be able to tell your story in a way that you're supported. And we're really hoping that we can increase awareness for people to be able to be supports to one another in the community, rather than being people in the community who may pass judgment. And the talk before this, and our talk as well, hopefully is emphasizing that being there non-judgmentally for somebody is probably one of the best things that you can do, just non-judgmentally listening. So a very great comment, and thank you for bringing it up. Farah, did you have something more to say?
Yeah, absolutely. Just trying to identify your support, trying to know who are those people that you can share that loss with, because you're right, it's difficult to talk with the greater community about what you're going through, but speaking with them, at least the people that you know, your friends, your family members, know that can actually understand what you're going through. It helps to be able to share your story, and to go online if there are online support groups, other ways that you can try to learn from other people's experience, to not feel so alone if you can't go to your greater community, inshallah, as well as there.
All right, so this is not a question there, but I think more for me, I have a question for you guys, and that's more about, we talk about women's mental health and postpartum psychiatry for women, but I think something that you mentioned in your video before as well is that 1 in 10 men have postpartum depression. So, how do we help bring that to awareness, and what are some things men can do, or women can do, and like, what are some tips on that, if you have some time?
That's really good. We need to do more.
Sorry, too loaded of a question. It's like a whole conference on its own, but
I did want to say though, I think it's a great question, and I'll let Farah answer. I just wanted to say that there is, one of my mentors at the Department of Psychiatry, he established the Father's Mental Health Network at U of T. So it's out of Mount Sinai, and you can be referred there for supports for people who do experience not just depression. Like, you don't have to be depressed to need to have the support, and to be able to access support. So there's that, and there is a website for that. And then there are some other resources that we can post, but it wouldn't be a different approach to women. Like, all of the same things would apply. That you, if you're noticing that you're feeling really low and you need sleep, you're not getting enough sleep, and that's really impacting you, or you're not able to connect with your little one, these are all signs that you need some extra help or support. And then I love that Farah mentioned the groups, because I know that without groups, for me, I don't know how I would, and still currently how I would kind of function as a parent, because the support groups are so important. So whether that's a WhatsApp chat group with your fellow fathers, whether that's an actual group, whether that's a virtual group that you start, and sometimes even initiating those groups yourself can be really useful, because there's usually lots more who are wanting and willing to join your group.
Yes, so true, so true. I have seen, for example, in the hospital, when there were families that were experiencing peripartum mental health issues, and then there was like a father's group or a group therapy open as well. So if we can have Muslim dad groups like that, developing that, having that, for example, in spaces like the masjid or in the mosque, again, so powerful. I mean, I think we've started to see at least one Alcoholics Anonymous group that I know of for Muslims. So having sort of that kind of a model would be so great and so powerful. And I think we also need to appreciate that mental health stigma against women and men can be a little bit different. Like, for example, the barriers against Muslim women often are around this idea of having to, keep shameful things or within the family. For men, sort of the barriers are a lot around how a real man, or toxic masculinity, a real man does not talk about his emotions, a real man doesn't cry, does not share his feelings, and so is then unable to get help because of the way we have often told our young boys and our men what it means to be a man. Changing that now as we become the parents for our new generation, for our sons, to treat them differently and to change that mindset, inshallah, as well.
Amazing. And I think someone gave a book suggestion in the comment section. It's The Postpartum Husband by Karen Kleiman. Not sure if anyone read that, but that might be a good start. And another question they have is, I don't know if you two are aware of any helplines for Muslim men. Anything specifically? I don't know if we find any. Would it be on the website, Arfeen?
Nasiha is not only a youth mental health line anymore. It's actually open to all ages, and so they support men and women who are Muslim. But you're right in saying that there is not a specific Muslim men's like there is for Nisa. You're right that there is not one specific one, but Nasiha does have, they do have males who are on the call as well as females, and they're open to all genders to call, and as is Nisa. Nisa doesn't specify that you have to be women to call the helpline. They'll help you regardless.
And I know a lot of Muslim organizations are working on exactly that problem. We do need to develop a safe space for men to be able to talk. Absolutely.
And I like the comment here by Imam Ayman about spiritual support being quite useful for men, and hopefully the masjid, and if you know that you have an imam who has training in mental health supports, or you find comfort in their approach, then that is a great support for you.
All right. Well, thank you, ladies. I think that was a wonderful talk. I know I learned a lot, and I'm sure everyone has. But it's time for a break.